Capitol Health. She will be talking about sleep problems in Chiari malformation. Okay, Dr. Deluca, anything that you would like to add about yourself, please feel free.
Okay, so I'm a neurologist by training. I've been doing sleep medicine for a long time. I started the sleep center at Mercer in 1988. I'm now still a medical director at Capitol Health, so I'm doing neurology and sleep medicine. They asked me to talk about sleep problems and said, gee, you can talk about anything, because unfortunately, having Chiari doesn't mean that you can't have any other problem on top of that. So we're not going to be able to discuss all of sleep medicine, but what I tried to do was to think of, the two main issues, and then there'll be time at the end for questions if you have it. So the two big things to think about is that with any chronic illness, there's disruption of sleep. We didn't used to appreciate that as much before. We sort of looked at it as, inevitable part of it, but we now recognize that chronic sleep disruption also affects how well you deal with the chronic illness. It affects how well you can cope, how well pain management works. So hopefully, dealing with sleep issues in folks with Chiari and other chronic problems is more at the forefront now than it used to be. And we'll talk about then how we can talk about some general things that you can do to help manage sleep problems with chronic illness, and I'll do that second. Because what I want to talk about first are specific sleep issues that can occur in folks with Chiari malformation. And that refers to sleep apnea. Now, when you hear sleep apnea, which gets a lot of press, it's a very common condition. When you hear folks talking about sleep apnea, generally they're talking about obstructive sleep apnea, because that's 90% of the sleep apnea that's out of there. However, folks with Chiari have another form called central sleep apnea, which, although it can occur in the general population, it's not very common. It's more common in people with Chiari. So we're going to talk about both of those. So what's obstructive sleep apnea? Well, it's a predominant form. It's very common. If you just took general population, depending on whose numbers you look at, it could be up to 9% of middle-aged folks, especially men, have some degree of sleep apnea. Things that make it worse is being male, which you can't change, obesity, pharyngeal crowding, and folks who are overweight are more likely to have it. And way back when, in the 1980s, when we were looking at sleep apnea, we only looked at people who were obese, and now we recognize it can occur even in folks who are thin, even in women, even in kids. But certainly gaining weight makes you more prone to it. Pharyngeal crowding, when your doctor looks in the back of your throat, you've got big tonsils, you've got a large uvula, you've got a recessed chin. There's things that seem to predispose to that, but they're not enough to cause it or cure it. And then the other thing is that folks who have other kinds of medical problems, most notably high blood pressure, heart disease, they call metabolic syndrome, which is high cholesterol, obesity, hypertension, and diabetes, those folks have a very high incidence of sleep apnea, so their doc should be looking to screen for that. So what's the presentation for sleep apnea? Well, I'm sure you probably all heard this. I mean, the triad is loud snoring, somebody says you stop breathing in sleep, and you don't feel refreshed in your sleep. Well, by the time all that happens, it's very clear that you need more sleep evaluation. However, sleep apnea is a spectrum. So it starts gradually. It tends to get worse over time. People don't come in and say it started last Tuesday. So they may put up with the symptoms for a lot longer than they should because they don't recognize them. So what are the subtle symptoms? Impaired concentration, feel like I'm getting old before my time, can't focus at work, depression, irritability. If you're chronically sleep deprived, you're not at your best, emotionally. And then things like morning headache, which goes away by midday, a dry mouth, stuffy nose. I keep water at the bedside because doesn't everybody need to drink water 3 times during the night? No. So there's lots of other more subtle symptoms. In kids, the symptoms are even more subtle. Kids in general have less sleep apnea than adults. But unfortunately, kids with Chiari start to really catch up to adults in the incidence of sleep apnea. And as we all know, sleepy kids or sleep-deprived kids don't look sleepy. They look cranky, they look irritable, they can't pay attention, so they have behavioral problems in school, they have poor school performance. They may get labeled as attention deficit disorder because they can't focus, they can't sit still, and in fact, it's because they're sleep-deprived. Kids can also snore with obstructive sleep apnea, although their snoring is usually less severe than in adults, and it's also more intermittent. Kids with obstructive sleep apnea tend to only have it in certain stages of the night, so it's intermittent. So it's hit or miss. If you tiptoe by the bedroom to listen for snoring, you might, be there at a time when the kid's apnea is not that bad. The other kind of interesting feature is unusual sleep positions. We all know our kids sleep sideways in bed and upside down, but kids who sleep with their head hanging over the side of the bed or really strange, usually hyperextended positions of the neck, that can be a sign that they're trying desperately to breathe in spite of the obstructive sleep apnea. So what happens in obstructive sleep apnea? Well, the airway collapses. There's something that obstructs it. So why is that? Well, in sleep, just naturally our muscles get more limp. We get floppy like a rag doll. So in everybody, and the upper airway until you get down to the windpipe is just a muscular tube. So in everybody, that tube gets limp and narrows a little bit in sleep. And if it narrows a little bit and vibrates, then you make a snoring noise. But if it narrows all the way to the point that it collapses, that's when an apnea, which is just the medical term for you're not moving any air. So if there's an apnea because the airway has collapsed, even though the person is trying to breathe, that causes drops in the oxygen level. And then the only way to recover is for the brain to wake the sleeper up and say, we're going to have to wake up, bring those muscles under waking control in order to take the next breath. So a person may wake up just long enough to take a breath and then go right back to sleep, never even remember it, but their sleep is disrupted, they have less deep sleep, the sleep quality is not good, and that over time leads to lots of other physiologic problems that we can now quantify, if you will. There's an increase in stress hormones that can lead to high blood pressure acutely during the night with every apnea, and then eventually high blood pressure that persists during the day, an increased risk of heart disease, heart attack, stroke, diabetes with high morning sugars, which makes no sense because you've been fasting all night. It's a sign of sleep apnea causing this stress reaction during the night. So let's change gears though. Obstructive sleep apnea is the common one that you hear a lot about. Central sleep apnea is the one that, frankly, you've got to be more aware of with Chiari. It's less common in general, except in certain conditions. Heart failure is one. So half of heart failure patients have some degree of central sleep apnea. Chronic narcotic use, which anybody with chronic pain can be on chronic narcotics. That can trigger central sleep apnea. And then a variety of neurologic diseases, the most important of which we're going to talk about today is Chiari malformation. The severity of central sleep apnea in Chiari tends to parallel the severity of the anatomic disease. So what happens in central sleep apnea? Well, there's no obstruction to the airflow. It's simply that the respiratory centers fail to trigger breathing. So there's a loss of respiratory effort. That also, of course, if you're not making any effort, you're not moving any air, that can cause drops in the oxygen level, but those drops are usually more subtle than you see in obstructive sleep apnea. However, the degree of sleep fragmentation, the need to keep waking up to take a breath and startle things again, can be as severe in central sleep apnea. A lot of times, folks have a mixed pattern. When you do a sleep study, you see some obstructive, some central, and that confuses the issue even further. But they can have more disruption of sleep than would be appreciated just by listening to their snoring. So the symptoms are more subtle. If someone listens very carefully, which means your bed partner's staying up all night, they may hear irregular breathing. There can be snoring, but it's usually milder than in obstructive sleep apnea. And there can be a lot of sleep fragmentation. So sometimes patients with central sleep apnea will come to me saying, I just can't sleep all night. I have insomnia. I wake up a lot. And in fact, there's a physical reason for it that they just didn't appreciate. So in general, they also have unrefreshing sleep. They have chronic sleep deprivation. They have impaired concentration. You just don't focus as well. You feel like you're not as mentally sharp. There can be learning disability in kids, and there can be mood problems. So what about sleep apnea and Chiari malformation? Well, I gave you the numbers for the general population, 4 to 9%, especially middle-aged, overweight men. But sleep apnea in patients with Chiari malformation is 50%, maybe 70%. And that's adults as well as kids. That's skinny folks as well as folks who are carrying too much weight. If you look at severe sleep apnea in Chiari patients, it's usually in adults, and it's usually thought because there's other reasons that they would have sleep apnea too. They put on weight, they have other factors. Central sleep apnea, which can be fairly severe, occurs in more than a third of patients with Chiari malformation. And as I talked to you about before, the severity correlates with the severity of the anatomic disease. So why do folks with Chiari malformation have sleep apnea more than everybody else? Well, there's theories, but nobody actually knows. One theory is that there may be compression of brainstem respiratory centers, and that results in diminished respiratory drive, and that's why you have central sleep apnea. And that's kind of supported by the fact that folks with Chiari who end up with successful decompressive surgeries, their central sleep apnea tends to get better. All right? So there must be something to do with the compression and the brainstem respiratory centers. In terms of obstructive sleep apnea, why should that be? Well, there's a theory that maybe lower cranial nerve compression affects the patency or the openness of the upper airway. And if that's the case, though, you'd say, well, gee, those nerves are affected during the day as well as at night, and these people aren't running around not able to breathe during the day. Well, the theory is then that if something is affecting how wide open you can maintain your throat, because you do need the lower cranial nerves to maintain the patency of the throat, when you go to sleep, where The control is slightly different. We tend to sleep lying down, not sitting up, and lying down favors collapse of the airway. Maybe just going to sleep in a recumbent position tips the balance to something that was already precarious to begin with. But these are theories. Nobody knows for sure why it is. But why do you need to know about it? And well, that's very clear. One is it's very common, and sleep medicine is just coming into its own in the last 30 years that I've been doing anyway, right? So it's become something that's more prevalent. When I was in medical school, nobody studied sleep medicine because we didn't know much about it. So sleep apnea in Chiari malformation is very common, and it's been under-recognized until recently. It has the same negative effects on quality of life. So if you never feel refreshed from sleep, you don't do your best, you don't enjoy life as you should. And there is long-term cardiovascular risk. So there's other medical reasons to be aware of it. The last and most acute is that folks with Chiari may at some point be facing surgery. Folks with sleep apnea have an increased risk of complications from anesthesia. So if you're talking about major surgery, you want to know if there's any other factors that you should be aware of in advance that could affect your risk with the surgery. It doesn't mean you can't have the surgery, it just means that folks have got to be paying attention to breathing. People with sleep apnea can have more difficulty with intubation for general anesthesia, and more importantly, more difficulty resuming normal breathing after the surgery because of the effects of medication, et cetera. So you don't want to run the risk of some problem in the recovery room. So you want to know about this before you go for surgery. So how do you diagnose it? Now I got everybody worried about it, thinking about your symptoms, thinking about what's going to happen. The only way to diagnose it is to actually do a detailed sleep study. Overnight polysomnography is the gold standard. It means you come to the sleep lab, you get all wired up, and you have electrodes on the head to tell how deep the sleep is, how continuous the sleep, what stage of sleep you're in. You have belts around the chest to measure how you're trying to breathe. You have sensors taped by the nose and mouth to measure how much air you actually move in and out with each breath. You have a clip on the fingertip that'll measure the blood oxygen level without being invasive or painful. And then while you're there, we do lots of other things. We have eye movement electrodes, we'll look at the heart rate, we'll look at the legs kick. Because while you're there, I want to make sure there's not something else besides sleep apnea. It shouldn't be a sleep apnea test, if you will, pass or fail. So there's lots of detailed monitoring, and because of that detailed monitoring, you can tell not only if there are apneas, if there's no airflow and drops in the oxygen level, but you can tell whether they're obstructive. Obstructive means that there's still respiratory effort, but there's no airflow, or whether they're central, which means we don't see any effort and we don't see any airflow. And I stress that because, unfortunately, the most recent, insurance issue, it would be to deny in-laboratory testing for sleep apnea, because they think it's cheaper if you do it as a home test. Home test means you get this little box with a few belts around it and a nasal cannula and one electrode to measure oxygen, and that kind of testing will not distinguish between obstructive sleep apnea and central sleep apnea. So folks with Chiari have to insist that if they're going to have sleep testing, it has to be done in a lab, because you need to distinguish which of the two components is there, which is preeminent. So let's say you've gotten to the point that you say, I had enough symptoms, I actually had a gold standard sleep study, and it shows that I have sleep apnea now, what do I do? Well, the presence of sleep apnea does not mandate surgical intervention for your Chiari. So the decision about whether or not you have surgery for the Chiari is based on lots of other factors you've worked out with your surgeon. However, if you do need surgery, your surgeon needs to know in advance that you have sleep apnea so they can take the appropriate precautions with anesthesia and pain medications, because narcotics can aggravate sleep apnea. If you do end up needing surgery, then the surgery tends to be helpful. May not be curative, though, so it'll help the sleep disorder breathing, and some folks with sleep apnea before surgery may not need treatment after surgery, although you might think about perioperatively managing someone with the other modalities that we have to make sure that the breathing is safe in the perioperative period. Let's say that you have sleep apnea, but you don't actually need surgery right now. You don't have to suffer with the sleep apnea. All the same standard treatments for both obstructive and central sleep apnea work in patients with Chiari as work in anybody else. So the treatment of obstructive sleep apnea, the gold standard is the machine, Cpap, which you've probably heard about. The initials are Cpap, stands for continuous positive airway pressure. Just describes what it does. If I'm telling you that in obstructive apnea, what happens is the airway gets so limp that it collapses, then the goal is to keep it open. Well, we don't know why it collapses, so nobody can cure it yet, but you can prevent the collapse if you blow a column of air down the throat. It's a very simple idea, and that's what Cpap does. There's a little machine, fits on your nightstand, some tubing, a mask that makes an airtight seal with the nose, and then it blows air, room air. The pressure of that air, that column of air in the throat, is enough to keep the walls of the throat from passively collapsing. It doesn't force air into the lungs, doesn't breathe for you, it's not a ventilator or a respirator, it just maintains a constant pressure, so now whenever you want to take a breath, the airway is always open and it works. So it works very well. It eliminates the apneas, the low oxygen levels, the sleep disruption from the very first night you use it. Has no side effects, no harm, no danger. The nuisance is you have to put it on every night because it only works when you use it. But if you use it and you feel that much better with it, you say, my gosh, that's a small price to pay. In order to set up the Cpap, though, it's not just go buy yourself a machine. You do come back to the sleep lab so that we can adjust the pressure. We want to find the lowest, most comfortable pressure that'll keep that particular airway open and make sure that someone's comfortable. We found the appropriate mask. The biggest issues using Cpap out at home are usually what's comfortable about the mask and what's the lowest pressure you can tolerate. But all that's definitely manageable. As a second possibility, there are oral appliances. They're called mandibular advancement devices. So I told you before that people who have a recessed chin tend to have more sleep apnea. Well, if you pull anybody's chin, even a normal chin, forward, you can actually open up the airway to some degree. The mandibular advancement devices are not as uniformly successful as Cpap. Cpap always works. The mandibular advancement devices work maybe 2/3 of the time. There's something that's custom made by dentists. The late night TV ads you're seeing about boil and bite devices don't work, so don't waste your money on those. And so a custom made device by dentist is pretty expensive. There is now a way, though, that you can tell prospectively by coming to the sleep lab and using a temporary device whether the thing would work for you, and then if it works in the lab, then you get a permanent device made. So there are other options. Treatment of central sleep apnea is a little more difficult. As I said before, a lot of folks have a combination of obstructive and central sleep apnea, so the first line may be just trying Cpap. And sometimes even with that combination, Cpap alone will work, and that's great. If it doesn't, though, up until a few years ago, we didn't have a lot of other good choices. And now there is another machine that goes by more initials, ASV, Adaptive Servo Ventilation. For all intents and purposes, it looks the same on your nightstand. It's a small machine, some tubing and a mask that goes around the nose. But the machine has a different mechanism in it that will actually protect a person from central apneas as well as obstructive apneas, so it can kind of kill two birds with one stone. You can set that up too by coming into the lab and titrating it and adjusting it, and it works extremely well. So if there's a combination, we can now guarantee that we can take care of that on one of these ASV machines. So why do you want to treat it? Well, you want to treat it because if you control the sleep apnea, you improve sleep continuity, you improve sleep quality. A person who's repeatedly waking up from light sleep to take a breath never gets into deep sleep. So with Cpap or ASV, you can sleep continuously, you can get the sleep that you need. If you get the sleep that you need, you feel better during the day, you're more alert, you're more energetic, and you think better. So if you're a kid, you do better in school. Even if you're an adult, you function better at work. And then there's the long-term benefits. 10, 20 years down the road, you can say, well, gee, I have less cardiovascular problems, I have less hypertension, diabetes, I didn't have a heart attack, didn't have a stroke, all those things that are good. Now we'll talk about other things. So sleep apnea obviously is the easy one for your sleep doc to fix because it's common, it's easy to recognize, and it's frankly very straightforward to treat. But there's lots of other things that can cause sleep disruption. And chronic illness, pain is a big one, and I don't have a simple answer for pain. And then you're also sort of stuck between a rock and a hard place because pain disrupts sleep, but unfortunately narcotics can also disrupt sleep. They can aggravate sleep apnea, they can cause daytime sedation, so that has to be something that's managed and ideally managed with your primary, treating physician for the Chiari. Medication side effects with daytime sedation is also a big problem. So a lot of the muscle relaxants cause, extreme sedation during the day, and if you're drowsy during the day, then you don't sleep as well at night. So all those things have to be, titrated ideally with your primary treating physician, but sometimes a sleep physician can be helpful in kind of looking at it with a fresh eye and trying to streamline the medication use. The one that is under an individual's control, though, is poor sleep patterns, and that often happens if you start sleeping badly for any reason, because you're in pain, because of medication side effects. It can sometimes start to take on a life of its own, and even after the other issues are resolved, if you're still sleeping poorly and don't have the knowledge about how you want to change this, then you can continue to suffer from sleep troubles that would be, not inevitable. So what are the principles of good sleep hygiene? That's the term that's used. Well, these are things your mother told you, but I'll tell you again. You want to go to bed the same time, you want to wake up the same time. So a regular sleep-wake pattern. And that because we actually have 24-hour rhythms in our body naturally that are much more than just sleep. There's hormone regulation, there's temperature regulation. Those are called our circadian rhythms because they're on about a 24-hour cycle. If We do things on this, we eat meals at the same time, we go to bed at the same time, we exercise at the same time. All those circadian rhythms get in sync, and then they promote deeper sleep when it's time to go to sleep. They're ready to wake us up before the alarm goes off because our body knows what to expect. People who are trying to fool Mother Nature and sleep at odd times and catch meals when they can and whose lives are disrupted, their circadian rhythms are still running on a 24-hour cycle, but they're not all in sync with each other. They're all kind of in conflict with each other, and so you don't do your best. The next thing is to make sure you have an appropriate sleep opportunity. I hear people all the time say to me, well, I just didn't get my 8 hours. There's nothing magic about 8 hours. How much sleep we need is actually genetically determined. We have some natural short sleepers and some natural long sleepers. And so what you've got to figure out is how much sleep do you personally need? How much sleep does it take for you on a consistent basis to feel refreshed? There's the shortest sleepers recorded, need 5.5 hours, and get by with 5.5 hours. And there's some folks who need 9 hours. And then 8 is kind of what's in the middle range, but it's by no means that you need no one would ever prescribe a certain amount of sleep to feel refreshed. And the other thing is you want to avoid prolonged time in bed at night, because a lot of times when folks sleep poorly, they say, well, I slept badly last night, let me go to bed earlier tonight. Or I was awake for a couple hours in the middle of the night, let me stay in bed longer in the morning. And that actually is counterproductive. For one thing, it disrupts your circadian pattern because your poor body doesn't know whether it's supposed to be awake or asleep. And the second thing is that they've actually shown, they did these with college students, they brought them into the sleep lab and paid them to sleep there a couple nights, which they loved, and said to them the first night, sleep as long as you want, and the next night they forced them to spend an extra hour in bed. They slept exactly the same amount on both nights, but the night they were forced to be in bed an extra hour, these college guys got up and said, oh, that was crummy. I feel tired. I feel unrefreshed. So you feel worse sometimes when you spend time in bed staring at the ceiling. Other things, you want to make sure there's no nighttime distractions. So that if you really feel you need to fall asleep with the TV or music, don't leave it on all night, because then that Vegematic commercial in the middle of the night is going to be loud and wake you up. You want to have dark lighting. The strongest stimulus to our circadian rhythms is the light-dark cycles. We are diurnal creatures, so when it gets dark out, we make certain hormones that tell us it's time to go to sleep. When it's light out, we say, hey, it's time to wake up and feel energetic. We all feel better in the summer when the days are longer, the nights are shorter. We kind of don't do as well in the winter. But so light is a critical feature, so you don't want to have bright lights on at night. You want to have dim lighting to kind of get you in the mood for sleep. A cool environment actually is better, so keeping your bedroom too cold rather than too hot. You shouldn't go to bed hungry, but you don't necessarily have to eat at night. The big one is things like caffeine and other stimulants. They can disrupt sleep. Caffeine disrupts sleep even more than you think. Coffee at dinner, and some folks can still disrupt their sleep later on. The use of drugs for ADD, the other stimulants, to just stay awake. Some of the antidepressants can actually disrupt sleep, so some of them are better taken in the morning than at night. And the other big one is alcohol. A lot of folks will say, well, I'll have a drink just to relax me and fall asleep. Well, alcohol actually fragments sleep. So as you metabolize alcohol over the next 4 hours, it disrupts your sleep. So if you're going to drink, you have to drink early. Or the other thing is if you have sleep apnea, even a small amount of alcohol can tip the balance between sleep apnea that's pretty mild and sleep apnea that's pretty severe. So you really want to avoid alcohol in the last 4 hours before bedtime. So why are all these principles there? I mean, is there any physiologic, background to that? Well, there's what's considered this two-process model of what regulates sleep. That there are two different processes that either compete or synchronize with each other. One is the homeostatic process. How long has it been since you last slept? So whatever your sleep debt is, our body feels the need to sleep again after a sustained period of wakefulness. For most of us, that's 16, 18 hours, and then we need to sleep again. And the second is the circadian process. We have these circadian rhythms. That's the underlying, 24-hour clock. So if you go to bed the same time every night, so it's the right time in your circadian clock, and you haven't slept for 16 or 18 hours before then, so you built up enough of a sleep debt, you have those two processes in sync with each other, and you actually get the deepest sleep. You feel the most refreshed in the morning. If you try to fool Mother Nature, stay up all night and go to bed at 5 a.m., yes, you can go to sleep because you've got a tremendous sleep debt here now, 24 hours, except it's the wrong time in the circadian clock, so you actually don't sleep as continuously. Your sleep is more fitful and you try to pull an all-nighter. Same thing if you say, I'm going to go to bed the same time every night, I'm going to follow those rules, but I took a nap at 5 in the afternoon. Then you go to bed without the proper sleep debt and you're not able to fall asleep or stay asleep. So what's insomnia? Well, sleep doctors look at insomnia as two things. It can be a symptom. Symptom is just someone says, I can't fall asleep or I can't stay asleep. And that could be a symptom of anything from sleep apnea to pain to depression, could be other things. It can also be a primary diagnosis. We don't understand as much about insomnia as a primary diagnosis as we should. You know, it's thought of there are some folks, a minority, who are actually born with a kind of hyperarousal state. They've been insomniac since childhood, but that's a minority. In most cases for adults, it's because it was triggered by something else, you know, a mood disorder, life stresses, and then it started to take on a life of its own. So even after everything else in life has calmed down, the sleep problem continues. And it's perpetuated then by this irregular sleep-wake pattern, napping, not having a set bedtime, a set wake-up time, spending too long in bed trying to treat yourself to more sleep when it's actually counterproductive. And then also, you know, we are sentient creatures. We try to make cause and effect. So if every night you get into bed and you sleep poorly, then you start looking at that bed and saying, I'm going to have a really rough time there. Sometimes people with insomnia sleep better when they go to a hotel, someplace where they have no expectations. So part of it is that we get this learned association that it's going to be a bad night. And then they get heightened anxiety about sleep, saying, oh my gosh, I slept badly for the last 3 nights. I'm going to sleep badly again tonight. You psych yourself out, if you will. So that's one of the other psychological issues that needs to be looked at. And the last is taking too many medicines, hypnotic dependence. The over-the-counter sleeping pills sleep docs hate, because usually what they have in them are just sedating antihistamines that have a very long half-life. So if you take it once or twice, you know, maybe it helps you sleep through the night. On a regular basis, it starts to leave you hungover the next day, and your body gets physiologically used to it, habituated very quickly, so it does less and less, and then you take more and more, and then you have more hungover sedation, and it's a problem. And worse than all that, when you finally say, okay, I don't want to take it anymore, you will clearly go through a physiologic withdrawal from the medication, so it makes things worse again. So how do I treat insomnia? What works the best? And I'm giving you all the reasons why it's difficult. The best is actually what they call cognitive behavioral therapy, which is that you work on a plan. And you work on a plan that's designed to regularize your sleep patterns, minimize some of this anxiety, and that's a, if you will, drug-free plan, and that works the best, and it works the most long-lasting. It's also the toughest one to follow through on. There may be a role for medication, but it should be supplementary, you know? So sleeping pills could be used, you know, in the short term, you know, an acute problem, and you don't want to get into a bad pattern, taking sleeping medication for a few nights, a week, that's acceptable. You don't want to do it on a long-term basis because you end up with potential for it being physiologically, you know, you're used to it, dependent on it. And also just even mentally. If you think your sleep comes out of that pill bottle, then you're going to just continue to believe that. So you want to minimize it, and I'll talk about how I sometimes minimize that, or how the recommendations for minimizing it. And the second thing is that if there really is a real underlying mood disturbance that's triggered this, then just talking about good sleep patterns may not be enough, and there may be a role for medication to treat the depression, the anxiety, and then you also follow a good sleep schedule. So the principles of this cognitive behavioral therapy is regularizing the rhythms, allowing adequate sleep debt so that we have this 2-process model where everything fits perfectly. Exercise actually is kind of useful. Exercise improves deep sleep, slow wave sleep that you feel refreshed with. It doesn't have to be going to the gym, breaking a sweat. You know, I want to raise the bar too high, but if you can do a 20-minute walk every single day. So the idea is it's consistent exercise that actually helps to promote deeper sleep. And you want to do that relatively early in the day. So unfortunately, a lot of folks will say, well, I'm working all day and the only time I get to the gym is 9 o'clock at night. And that's in some ways counterproductive, because if you go to the gym and you work out a lot and you raise your body temperature, that's exactly the opposite of what your natural circadian rhythms are doing before it's time to go to sleep. So what's happening before we go to sleep, and someone's a good sleeper, is body temperature is starting to drop. And if you then do something that raises your body temperature late in the evening, you give your body conflicting signals. And the last one is to overcome whatever performance anxiety there is about sleep quality. So people say, well, I start off in my bed and I can't sleep there, and then I go down the hall, and then I go to the couch, and eventually I can sleep. It's because they finally move to a room where they have no expectations. What you want to do is, you want to sleep in the master bedroom, but you want to say, if I get into the master bedroom and I don't fall asleep within 20 or 30 minutes, I'm going to get out of there. I'm going to go do something else. I'm going to distract myself. I'm not going to lie there getting more frustrated in the same room. And then I'm only going to return to the room when I'm ready to sleep. And I'm not going to allow myself to sleep anyplace else. So the idea is, you kind of, it's a now or never proposition. So you say to your body, you're going to have to do this. But the second is that if there is an anxiety about falling asleep in that room, you don't compensate for it by allowing yourself to sleep in an odd place where you don't sleep well anyway. So how do I treat someone with this? It really has to be very individualized. I know you can go online, you can get all kinds of menus for what to do with cognitive behavioral therapy, and they all have good principles, but the idea is that it has to be individualized. So first I talk to somebody and say, when do you go to bed? What's the circumstances? What happens during the night? What happens during the day? We really go through the whole 24 hours. And then we have to establish a strict schedule, and the best way to do that is with the wake-up time. Because assigning bedtimes, I could do from now until doomsday. Doesn't mean anybody's going to fall asleep because I said it's bedtime. But if we agree as to when you're going to wake up, that you can do, because that's under willful control. And that's where you start the circadian clock. So you say, all right, what's the earliest you have to be up for whatever your commitments are? And frankly, you should stick to that 7 days a week. If I'm really generous, I might give you an extra half hour or an hour on a day off. But you don't want to have a marked discrepancy in your schedule, because that, as I talked about before, disrupts your circadian patterns. So you pick a strict wake-up time and you say, no matter what, I'm on my feet that time every day. Bright light in the morning is actually very helpful. It's easy to prescribe that in the summertime because you can just go outside. But bright light tells your brain it's time to wake up. It's alerting. It starts to set that circadian clock better than anything else I can do medication-wise. If you can't have bright light, or you have to get up at 5 o'clock in the morning in the wintertime, you can actually buy light boxes. And a light box for half an hour gives you bright light. Doesn't mean you sit in front of a box. It means you put it next to you while you're putting your makeup on and you bring it in to have with your breakfast. But if your eyes can perceive that bright light, it stimulates that as the wake-up time. The next thing is that you want to avoid napping, because napping robs you of the sleep debt, and it makes it harder for you to fall asleep at night. There's nothing intrinsically wrong with napping in good sleepers if they do it, early enough, short enough. But people who are having sleep troubles, I think it's best not to allow napping at all. Exercise is good, but set the bar low. A 20-minute walk over your lunch break, a walk to the car or walk to work instead of, a long drive. Something that you can do on a consistent basis. And then in the evening, you want to be able to relax. You want to start to wind down. So you should get ready for bed early. You don't want to go wash your face, brush your teeth, and all that kind of stimulating stuff at the last second before you get into bed. You want to do it earlier. So you would get ready for bed early in the evening, use dim lighting, stay out of the bedroom. A lot of people spend their entire lives in the same bedroom. Well, you can't do everything in that same bed. It's sleep and sex, and everything else should be in a different room so that you only have positive associations with that bed. So that you would get ready for bed early, stay out of the bedroom until it's time for bed. And then once we've established what your wake-up time is, we kind of back it up. And in general, when I'm working with someone with insomnia, I deliberately restrict their sleep opportunity. I deliberately narrow it down. If someone says to me, oh, I think I needed 8 hours to feel good, fine, I'll give you 7 to start. And when you tell me that you can sleep 7 hours continuously and you're still tired, I give you 7 1/4. So the idea is that you want to train your body to be efficient about it, and you do that by restricting it. So you don't go to bed until you're tired. You go to bed at the same time. And now, instead of getting into bed saying, okay, quick, how quick am I going to fall asleep? Write it down in my sleep diary. What's my score going to be? You say, I'm getting into bed to relax. I'm done with all my other duties. I'm done with whatever work I brought home from the office. I'm done with all my household duties. Now this is my time, my private time. And what you want to do is find something that's relaxing to do in bed that kind of gives you the groove. So if you have been watching television all evening, maybe you should read or do crossword puzzles when you get into bed. If you've been reading all evening, maybe you should read, something lighthearted and not, work-related, so it's relaxing. You can listen to music. You can do correspondence. You can do Sudoku. You can do just something. You can knit. You can do something that is relaxing that you, again, only do right before you get into bed, so it becomes this paired association. Pavlov used to ring his bell and feed his dogs, and if he rang the bell and didn't feed him, they'd salivate anyway. You want to develop something like that for yourself. You say, I do this every night, and now I fall asleep very well. And then, once you turn the lights out, if you don't fall asleep quickly enough, which I give you usually half an hour, you drag yourself out of bed, you go somewhere else. As soon as you get sleepy, you're allowed back into bed. And I don't really care if you stay up all night or you stay up for 5 hours and you finally get to sleep, an hour before we said wake-up time is. You say, when the wake-up time comes, that was it, I blew it. For most healthy folks, you could survive a night of sleep deprivation. The theory is, if you really stick to the rules, by next night, you're going to feel better. So it's the idea that there's some short-term pain for some long-term gain. It also gives you a structure, because part of what happens with insomnia is you start to wonder, what should I do? Should I do this? Should I do? You don't want too many choices. You want to have exactly what the program is. And then for folks who have really been using, say, sleeping pills on a fairly regular basis, it's hard to give it up completely. The last little life preserver is, well, if you follow the rules one night and you have a crummy night, you go, tomorrow night you'll sleep better. And if the next night you don't sleep better and you make a liar out of me, then the third night, when you get into bed, you have a sleeping pill. And you say, okay, now I've guaranteed myself one good night, and I'm going to go back on the straight and narrow. Because you want to make sure that you don't feel strung out and helpless on this, but you also want to take control. So those are my tidbits.
What is the sleeping rhythm for a young child that you would consider normal? I have a 7-year-old male with Arnold-Chiari malformation and EDS, and he pauses breathing as he's sleeping.
Yeah, so I would worry that he could have sleep apnea.
Yeah.
Yeah.
I mean, but how many repetitions is normal for that age range?
So kids need more sleep than adults. So a kid who's that age probably needs 9 to 10 hours of sleep. Probably does not need napping. Needs to be in bed the same time, wake up the same time, all that's good. If you catch him with irregular breathing, that is not normal. Kids have perfectly rhythmic breathing. Adults can here or there have a few pauses in their breathing. On a sleep study, they can have up to 5 apneas an hour, and that's considered acceptable for adults, and you don't get too excited about it. Kids, it's under 1 apnea an hour, right? So, and again, they change the definitions of these apneas, but it's certainly not more than 1 or 2 an hour, and if it's clearly an apnea on a sleep study, anything more than 1 apnea an hour is abnormal in a kid that age.
But what is the normal repetition of, inhale, exhale that is acceptable?
I mean, counting their breaths per minute, so they're probably 12 breaths per minute.
Okay.
But what matters not so much is, whether he's slow, deep breathing versus irregular breathing. So if you catch him, and again, in a kid on a sleep study, an adult, it has to be 10 seconds you go between breaths to call it an apnea. In a kid, because they breathe faster than adults, it is 2 respiratory cycles, which is going to be hard to do clinically watching your son breathe. You're going to make yourself crazy listening to this. But if you were to listen and say, okay, he's going 3 or 4 seconds between a breath, and he's now gone 8 seconds without a breath, that's 2 respiratory cycles. When in doubt, I would suggest that he really get tested, though.
Okay.
Do y'all use the subcutaneous CO2 monitor when you're doing the sleep studies in the clinic?
You can do end-tidal CO2, which is more useful in kids than in adults, but it's really hard because what happens then is that there's lots of ways that the CO2 gets dispersed in your recording environment, and you really can't, it's harder to measure unless you have a very tight-fitting mask, which then kids hate.
I was it's a sticker that you put on. My daughter's on a Bipap.
Yeah.
She had pseudotumor. She was having increased intracranial pressure. We took her shunt out because she was over shunted. So we did an ICP monitor and watched her pressures, and so they noticed that during the day she had normal pressure or negative. When she went to sleep, her pressures went up to 50 in the 50s, which is really high.
Right.
It would cause her oxygen levels dropped,
Okay.
and her CO2 increased, and they thought that the CO2 was doing it, so they put this subcutaneous.
Right.
So my thing is, now she's on a Bipap, and it actually, her headaches are gone because she would have a lot of apnea episodes, and she'd stop breathing and when she was sleeping, but she has PR as well.
Now I understand what happens is when we breathe in oxygen, we breathe out carbon dioxide, so that you can monitor from breath to breath what's happening with carbon dioxide, and that's a surrogate for what's happening with the oxygen levels. In addition, there are folks who have hypoventilation, which means they don't breathe very deeply, so they're not oxygenating well, and they're not blowing off carbon dioxide well. So that, over time, gradually can increase your CO2 levels. And there are transcutaneous monitors that monitor transcutaneous CO2. Now, that's not going to tell you what's happening breath to breath because it doesn't have that fast a recovery time, but it would tell you what's happening as a trend over the night. And what it sounds like is it trending toward retaining CO2, and that actually gives you morning headaches. So, and they did the appropriate thing. Now, Bipap is bi-level positive airway pressure, and it was what we used before there was ASV, and sometimes it does work. And bi-level just means that you are breathing in with more respiratory or more inspiratory support, and when you go to exhale, the machine backs off. It's a lower level of pressure. And some of the bi-level machines also have it so that they can trigger breaths if you don't breathe quickly enough. So it's a bi-level machine that kind of functions like a respirator in that it monitors how often you're breathing, and if you don't breathe fast enough, it kicks in. The ASV machine is a different mechanism, so that it doesn't necessarily gives you breaths, but it monitors the tidal volume, how much you're moving in, how much you're moving out, and then it gooses you to breathe. So at some points you might use an ASV machine, but if with ST,
a bump up with the
exactly. So there's.
She's got it monitors. I mean, they go straight to her doctor's office the whole time because so that they know exactly what.
Right. All these monitors have it. They go to the cloud, and if you want to go visit it from the cloud, you can pull it back down. Yes.
Over here. Okay.
Oh, sorry, I'm doing it in the wrong order, but I'm going to be here till the end, so it doesn't matter.
Should I go?
Go ahead.
Okay. I have a 5-year-old who just had decompression a year ago. He has a history of laryngomalacia, pharyngeal dysphagia. They've noted paradoxal vocal fold dysfunction. It's been called abnormal vocal function, a laryngeal cleft, mild sleep apnea, but no one's done anything to address the sleep. So what would you recommend?
He had a sleep study?
Because a lot of what
Yeah, he has a sleep study that said he has sleep.
Here in New Jersey through CHOP, a sleep study, and it said mild sleep apnea. And I talked to the pulmonologist, the ENT, and they say,
Don't bother?
despite all of this list, nothing. But yet we still have the issue.
Yeah, you know, I mean, I look at it like, you know, Cpap works wonderfully, and, you know, there's no risk. Now, in a kid, it's a little more, you know, anxiety-provoking perhaps to use it, but I have lots of kids who do use Cpap well. When in doubt, I might push to say, can we do a trial of it?
Okay.
And if you feel better and you look better at the end of that month, it's not going to hurt you. You have tremendous benefit potentially to have gained from that. It's non-invasive, it's completely reversible. So they may be saying to you, no, we don't want to do any surgery and try to correct his laryngomalacia. We don't want to do, you know, nothing, it's not that bad. But frankly, as I say, the cutoff for kids is an apnea-hypopnea index of 2 an hour or an apnea index of 1 an hour. So to say that you ought to think about treating it. So I might, if he's got other symptoms, I might push it. Maybe your sleep docs just don't appreciate how symptomatic he is in daytime stuff.
So sleep doctor, that's what I need to be looking for?
Yeah, so I mean, if he,
Because it's always been the pulmonologist
So-
that sent me.
well, you know, sleep medicine is the kind of field that you can come into from pulmonary, from neurology, actually more pulmonary than neurology now. I'm one of the old-fashioned ones who started off being neurologists, were the ones who did sleep medicine, and now it's mostly pulmonologists. But CHOP has an excellent pediatric sleep clinic, and you could certainly, has he been seen by anybody there? So then I'd make sure that he was...
a team, but just pulm.
Anyway, so there are, and I think they have their sleep specialists, or I think either pulmonologists or neurologists, they may have a little of each, and make sure that he's seen by somebody who's also a sleep specialist in addition to pulmonologist to say, what else could we do? And worst case scenario, you tried it and it, you know, it didn't make him enough better, it wasn't worth it, you haven't heard anything. And kids can learn to adjust to this. You know, so I have some kids, I mean, the other one is, big one is Down syndrome kids have a lot of sleep apnea, and you would think how difficult that might be. I have Down's kids that just say, I can't wait to put my machine on. So you can learn to do this, and if you feel better with it, then you want to use it.
I haven't slept well in years. Sometimes it's emotional. I'll start thinking, focusing on silly things and stay up just thinking, can't stop my brain from functioning. Sometimes it's physical. Sometimes I'm just awake. But my neurologist thought I might have apnea, so I had a sleep study. No sleep apnea. Several years later, I was still complaining about it. I had a second test. No sleep apnea. But I still don't sleep well. Sometimes even if I thought I've slept through the night, and I'll feel good for, you know, a couple of hours, next thing I know, I would like to take a nap. I want to get back in bed. It's just crazy. So
Right, so those are the ones that are the tougher ones to treat. It's much easier for your neurologist to treat sleep apnea because that's straightforward. Right. But it might be worth seeing a sleep specialist to go through in detail what's happening with your pattern, how can we adjust it. It has to be an individualized, you know, plan. And there may be a role for occasional backup medication, but you got to get you back on the straight and narrow. There's no reason to be, you know, kind of relegated to poor sleep for forever. And right now, when I hear you talking, you don't sound like you expect to get a good night's sleep. No. You know, it's it would be, you know, unusual, and you should come to expect a good night's sleep and be annoyed with anything less.
And I meant to say, most of my you know, sleep study, my sleep habits are fairly good. I mean, I was listening to it. She said, yes, I check that off. I do that. I do that. I'm not saying it's every night that I'm perfect.
But that's it. What I'm going to say to you is that it should be.
Yeah, right. But I'm saying, I would say most of the time, I've come to follow these habits, and they don't make a difference.
What I will tell you is that I often hear, no offense to you, but I often hear people say to me, oh yeah, I do all that, I do all that. And then if we really come up with, I give people a written set of instructions, and you have homework. And if you really look at it for 2 weeks, you know, you may say, gosh, I cheated more than I realized. And if you get back, and again, if you do it right, usually you will feel worse before you feel better. So I let you know that up front. And it may be worth seeing somebody. I mean, if you've been seeing your neurologist, you might want to see a sleep specialist to be able to see if there's any other way you can finesse it, because it is the same basic data, but it depends on how you make it happen. Yes.
If you're having problems sleeping and you might only be sleeping 1 to 3 hours a night, okay, how do they do a sleep study on a person like that? Do they start it up when they do fall asleep? Because, you know, you could be there until 5 o'clock in the morning and then find that you sleep 5 to 8.
Well, you know, a number of things. If I have somebody with a completely disrupted schedule, I do try to get them on a better schedule before you come into the sleep lab, because you want to get your money's worth. Our sleep lab is adjustable, so if I have somebody who's a night shift worker who always goes to bed at 1 a.m. and gets up at 9, we can adjust the timing that we do the testing. And then the other point is, quite honestly, a lot of times people sleep more than they realize, you know. So you come to the sleep lab and you may think you only slept 3 hours, and I say, guess what, I got 6 or 7, you know. So part of it, because our sense of, it's called sleep state misperception, our sense of timing during the night becomes very distorted and you really don't know. So you do your best. If someone is, and then you bring them into the sleep lab with a modification of the timing within reason to match up the person's own sleep schedule. In someone who is chronically taking sleep medication, then frankly I'd have them take the sleep medicine when you come to the sleep lab, because if, and it happens very rarely, if you come to the sleep lab and stay awake all night, I will not learn anything more than I already knew from talking to you. So I really need to see what's happening when you're sleeping, so that we would not prohibit you from taking the sleep medicine the night that you were there, because, you know, there's still other things. And frankly, you get to the lab early enough. A lot of times just being in a different environment, the technicians are very sweet, you know, you kind of feel tucked in, and you may sleep better than you thought. So it's, in all the 30 years I've been running the sleep lab, it's been extremely rare that I've had someone who really didn't give me enough sleep to know what was going on. Yes?
I have this, well, my doctor told me I could take Lunesta. And I just had this, since I was a kid, I always had this crazy numbness tingling in my arm. And everything's heightened at night when I lie down in terms of pain or what have you. The only way I seem to fall asleep is if I take Lunesta, and I've tried Apnea, which I don't like. But I still wake up every single day feeling zonked. But I think I'm sleeping throughout the night. Can you still have the apnea with the medicine? Is it the medicine? Is it the...
Those are all good questions, you know, and I can't, there are a number of things besides, you know, when you talk about funny feeling that you have that's heightened at night, you can worry about restless legs, which can affect arms too, so there's other issues. Lunesta would just kind of cover up whatever it is. And the trouble with Lunesta is it's got a long half-life, and if you take it night after night after night, particularly women, you may get hungover sedation from it, which you don't even appreciate as much. And then there's the psychological dependence. I can't sleep unless I have this pill. And so it sounds like a vicious cycle. I don't think anybody can, just talking to you, know whether or not there's anything else going on physically during the night. But if it's been going on long enough and you've tried other empiric treatments and you're not getting better, my attitude is at that point we need to see what's really happening. I don't send every insomnia patient to the sleep lab, but if I can't get you better in a few months, then I have to say, did I miss something else? And it's worth coming to the sleep lab to see if there's another piece to it. Yeah.
Any other questions?
Okay.
I have a question.
Yeah.
You said early on that you should try to push for like an in-place sleep study. What if you've already had surgery decompression for your Chiari? Would your insurance company still inhibit you from going in?
But you still have Chiari, as far as I'm concerned. Yes, you've had surgery. It's hopefully better. But, you know, and we talked about how folks with Chiari, although sleep apnea can get better with the surgery, it's not guaranteed to be curative. And then the key is that you stress to them that there is the question of central sleep apnea. And the insurance company should well recognize that if there's a question of central sleep apnea, that cannot be answered by doing home testing.
Okay. My second question leading up to that is sleep apnea a hereditary thing?
Yeah, there is some familial clustering, they call it. So if you have a first-degree relative with sleep apnea, that at least doubles, maybe quadruples your own chance of having sleep apnea. But that's mostly for the obstructive form, you know, because that's by far and away the most common form of sleep apnea in the general population.
I find myself as I'm getting older, even my husband will say to me, if like we're sitting at night watching a movie, he says, man, you're breathing really heavy, or, you know, like, and that's stuff that my father had said to me.
Yeah.
So I'm just curious.
Yeah, it does. I mean, it's not enough to say that everybody who has a relative with sleep apnea needs to be tested, but it seems to make you more prone to it. Okay. Thank you.
Thank you.